All right, when you're deep in board prep, you know there are some topics that are just guaranteed to show up. And today, we're hitting one of those classics with a high-yield review of acute pericarditis. Let's dive right in.
So, let's kick things off with a classic USMLE-style question. Picture this. A patient walks in with sharp chest pain. They tell you it's awful when they lie down, but it gets a lot better when they sit up and lean forward. Right away, your brain should be firing, and one diagnosis should be jumping right to the top of your list. If you're thinking acute pericarditis, you are absolutely on the right track.
So what is actually going on here? Well, at its most basic level, acute pericarditis is just inflammation of the pericardium. That's the thin, two-layered sac that surrounds your heart. You can kind of think of it like this protective sleeping bag for the heart. And when that sac gets angry and inflamed, you get all the classic symptoms we're about to cover.
Look, for the USMLE, pattern recognition is absolutely everything. And the good news is acute pericarditis has a very distinct, super testable pattern that you just need to know cold. So let's break that pattern down right now. Here it is. This is the money slide. First, the pain is pleuritic, which is a fancy way of saying it's sharp and gets worse when you take a deep breath or cough. Second, and this is the absolute giveaway, the pain is positional. It's way worse when lying flat and gets better when the patient sits up and leans forward. Why? Because that simple movement physically pulls the inflamed pericardium off the chest wall and diaphragm, which eases the friction. And finally, the ECG, you're going to see diffuse ST elevations. Now, that word diffuse is so important here. Unlike a heart attack, right, where the ST elevation is usually localized to certain leads that point to a specific blocked artery, in pericarditis, the inflammation is all over that sac surrounding the heart. So you see these ST elevations pretty much everywhere on the ECG. It's a global problem, not a focal one, and the ECG shows you that perfectly.
Okay, so we know what it looks like. We know the classic signs. But to really lock this in and be ready for those tricky second and third order questions, you've got to understand why this happens. Let's take a quick look under the hood.
The pathway is usually pretty straightforward. It often kicks off with some kind of trigger, and the most common one by far is a viral infection, like Coxsackie virus. Your immune system, of course, rushes in to fight it off, but in the process, it causes all this inflammation right on the pericardium itself. And as a result of that inflammation, you can get fluid leaking into that potential space, which leads to a pericardial effusion. It's just a simple, logical cascade of events.
All right, let's talk about what might be the single most important part of this review for your boards. This is where they'll try to trick you. Let's talk about the common traps and exactly how to sidestep them.
This is the classic mix-up. Both pericarditis and a myocardial infarction can show up with chest pain and ST elevations. I can almost guarantee you'll see a question that tries to make you confuse the two. So knowing how to tell them apart every single time is absolutely crucial.
Think of this slide as your cheat sheet. Let's drill it. Pericarditis, diffuse ST elevation. NMI, localized. Pericarditis, sharp, pleuritic, positional pain. NMI, that classic, crushing, elephant on the chest pain that doesn't change when you move. And finally, nitrates might help an MI, but they will do absolutely nothing for the inflammatory pain of pericarditis. Memorize these differences.
Let's lock in these high-yield traps right now. Trap number 1, the ECG mimicry. Just remember, pericarditis is diffuse and MI is localized. Trap 2, the nitrate test. If they tell you the pain is not relieved by nitrates, that should make you think pericarditis. And trap 3, pulsus paradoxus. That's that big drop in blood pressure when you breathe in. You do not see this in simple pericarditis. That is a sign of a much more serious complication called cardiac tamponade. Don't mix those two up.
Okay, we have covered a ton of ground, so let's boil it all down. If you're walking into your exam and your mind goes blank, what is the one core concept you need to remember for acute pericarditis?
This right here, this is your quick recall triad. Positional chest pain, a pericardial friction rub, that's a scratchy sound you'll hear on auscultation, kind of like leather rubbing together, and those diffuse ST elevations. If you see that combination on an exam question, you've nailed it. Burn this into your memory.
So let's wrap up with one last question to take you to the next level. You've correctly identified the pattern. You've sidestepped all the classic traps. Now what? What's the next step? The whole problem is inflammation, so you need to treat that. What's the first-line drug class you're going to prescribe? Figuring that out is your next step to truly mastering this topic. Thanks for joining me for this review.